Septic shock, immediate antibiotic administration within 1 hour. Septic shock affects over 19 million people globally each year, with an in-hospital mortality rate of 30 to 50%. It results from a dysregulated host response to infection, leading to systemic inflammation, endothelial dysfunction, and circulatory failure. Diagnosis requires meeting sepsis 3 criteria: suspected or confirmed infection, SOFA score greater than or equal to 2, and vasopressor requirement to maintain mean arterial pressure mmHg greater than or equal to 65 mm of mercury or serum lactate greater than or equal to 2 millimoles per liter despite adequate fluid resuscitation. Immediate administration of broad-spectrum intravenous antibiotics within 1 hour of recognition is mandated by IDSA, Surviving Sepsis Campaign, SSC, and NICE guidelines to reduce mortality by up to 7.6% per hour delay. Key points. Note: mortality increases by 4% per hour delay in antibiotic administration beyond 1 hour of septic shock recognition, HR 1.04 per hour, 95% CI 1.02 to 1.06. Kumar et al., 2006. Broad-spectrum antibiotics must be administered within 60 minutes of septic shock identification or first recognition of hypotension with lactate greater than or equal to 4 millimoles per liter. Surviving Sepsis Campaign 2021. Empiric therapy should cover gram-positive, gram-negative, and anaerobic organisms. For community-acquired septic shock, piperacillin-tazobactam 4.5 g4 every 6 hours is recommended by IDSA. Norepinephrine is first-line vasopressor, initiated at 0.05 to 0.1 mmHg/kg/min, titrated to achieve MAP greater than or equal to 65 mm of mercury, SSC 2021. Blood cultures should be obtained before antibiotics in 90% of cases, but should not delay antimicrobial therapy beyond 45 minutes, IDSA 2023. Lactate clearance of greater than or equal to 10% within 6 hours is associated with 28% relative reduction in mortality. Jones et al., 2010. The sequential organ failure assessment, SOFA, score greater than or equal to 2 defines organ dysfunction in sepsis, with each point increase associated with 12% higher mortality. Vincent et al., 1996. For MRSA risk, vancomycin 15 to 20 mg/kg4, actual body weight, every 8 to 12 hours, target trough 15 to 20 mmHg/ml, should be added, IDSA 2020. In penicillin-allergic patients with anaphylaxis history, meropenem 1 g4 every 8 hours may be used if allergy is non-IgE mediated. Otherwise, aztreonam 2 g4 every 8 hours is preferred. ACAAI 2023. Fluid resuscitation with 30 ml per kilogram crystalloid within 3 hours reduces mortality by 15% compared to delayed fluid. Process Trial, 2014. The Surviving Sepsis Campaign recommends against routine use of hydrocortisone unless patient remains hypotensive after 30 ml per kilogram fluids and vasopressors. SSC 2021. Mortality in septic shock is 35 to 50% at 28 days, with each hour of antibiotic delay increasing absolute mortality by 1.2%. Levy et al., 2018. Overview and epidemiology. Septic shock is defined as a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities substantially increase mortality. The ICD-10-CM code for septic shock is R65.21, severe sepsis with septic shock. According to the Global Burden of Disease Study 2017, sepsis affects approximately 48.9 million people annually, with 11 million sepsis-related deaths, 20% of all global deaths, of which 19.2 million cases meet criteria for septic shock. The incidence of septic shock in high-income countries is 240 to 300 cases per 100,000 population per year, while in low- and middle-income countries, it exceeds 500 per 100,000 due to limited access to critical care and delayed recognition. In the United States, septic shock accounts for 270,000 deaths annually, representing 1 in 3 hospital deaths, with an estimated 270,000 annual cases requiring ICU admission. The age-adjusted incidence has increased by 9.3% per year from 2009 to 2019, largely due to aging populations and increased comorbidities. The median age at presentation is 68 years, IQR 56 to 78, with a male-to-female ratio of 1.3 to 1. Racial disparities exist. Black patients have a 1.6-fold higher incidence, RR 1.62, 95% CI 1.48 to 1.77, and 1.4-fold higher mortality compared to white patients, independent of insurance status or comorbidities. Pathophysiology. Septic shock arises from a complex interplay between pathogen-associated molecular patterns, PAMPs, and host immune responses, resulting in a dysregulated systemic inflammatory cascade. Key PAMPs include lipopolysaccharide, LPS, from gram-negative bacteria, peptidoglycan and lipoteichoic acid from gram-positive organisms, and fungal beta-glucans. These bind to pattern recognition receptors, PRRs, primarily toll-like receptors, TLR2, TLR4, TLR5, triggering NF-kappa B and MAPK signaling pathways, leading to massive release of pro-inflammatory cytokines, TNF-alpha, IL-1 beta, IL-6, IL-8. Serum IL-6 levels greater than 1000 pg/ml correlate with 28-day mortality of 62%, versus 18% if less than 1000 pg/ml. Simultaneously, anti-inflammatory mediators, IL-10, TGF-beta, are upregulated, leading to a state of immunoparalysis, where monocytes exhibit reduced HLA-DR expression, less than 30% of normal, and impaired antigen presentation. This biphasic response, early hyperinflammation followed by immunosuppression, underlies the high risk of secondary infections. Endothelial activation results in glycocalyx shedding, increased vascular permeability, and microthrombosis via upregulation of tissue factor and suppression of protein C. Activated protein C levels fall by 50% within 6 hours of shock onset, contributing to disseminated intravascular coagulation, DIC, which occurs in 35% of cases. Clinical presentation. The classic presentation of septic shock includes fever, T greater than 38.3 degrees Celsius or less than 36 degrees Celsius, in 78% of cases, tachycardia, HR greater than 90 bpm, in 92%, tachypnea, RR greater than 20 per minute, in 85%, and hypotension, SBP less than 90 mm of mercury or MAP less than 65 mm of mercury, in 100% of cases by definition. Altered mental status, GCS less than 15, is present in 65% of patients, often manifesting as confusion or agitation. Skin manifestations include mottling, livido reticularis, in 45%, which correlates with 28-day mortality of 58%, versus 29% without mottling. Urine output is less than 0.5 milliliters per kilogram per hour in 70% within 6 hours of presentation. Atypical presentations are common in vulnerable populations. In patients greater than 75 years, fever may be absent in 30%, with hypothermia, less than 36 degrees Celsius, occurring in 22%. Diabetics may present with normothermia despite severe infection due to autonomic neuropathy. Immunocompromised patients, e.g., on corticosteroids, chemotherapy, may lack leukocytosis. 25% have WBC 4000/μl or 12000/μl. In cirrhotics, baseline tachycardia and encephalopathy may mask early signs, delaying diagnosis by a median of 4.2 hours. Diagnosis. Diagnosis of septic shock follows a step-by-step algorithm based on the Sepsis 3 definition, JAMA, 2016. Step 1. Identify suspected or confirmed infection, clinical, radiological, or microbiological. Step 2. Assess for organ dysfunction using the SOFA score, Appendix 1. A rise of greater than or equal to 2 points from baseline indicates sepsis. Step 3. Determine presence of circulatory failure. Persistent hypotension requiring vasopressors to maintain MAP greater than or equal to 65 mm of mercury and serum lactate greater than 2 millimoles per liter after adequate fluid resuscitation, greater than or equal to 30 milliliters per kilogram crystalloid. Laboratory workup must include CBC, WBC less than 4,000 or 12,000/mmol in 70%, basic metabolic panel, BUN greater than 20 mg per deciliter, CR greater than 1.2 mg per deciliter in AKI, liver function tests, AST/ALT 2 times ULN in 30%, coagulation panel, INR greater than 1.5 or APTT greater than 60 seconds in 40%, and arterial blood gas, pH less than 7.3 or base deficit 5 milliequivalent/L in 60%. Lactate should be measured immediately. Levels greater than 2 millimoles per liter have 79% sensitivity for shock, and greater than 4 millimoles per liter predicts 47% mortality. Blood cultures, 2 sets, aerobic and anaerobic, from different sites, should be drawn before antibiotics in 90% of cases but must not delay therapy beyond 45 minutes. Key points: QSOFA, greater than or equal to 2 points, RR greater than or equal to 22, altered mentation, SBP less than or equal to 100, sensitivity 73%, specificity 67% for ICU admission/mortality. SOFA, greater than or equal to 2-point increase, mortality risk 10% at score 2, 50% at score 6, 90% at score 12. Apache 2, score greater than 25 correlates with 50% mortality. Management and treatment. Immediate stabilization begins with the ABCs, airway, breathing, circulation. Endotracheal intubation is indicated for GCS less than or equal to 8, respiratory failure, PAO2/VO2 less than 200, or inability to protect airway. Non-invasive ventilation is contraindicated in shock due to risk of delayed intubation. Continuous monitoring includes ECG, pulse oximetry, invasive arterial line, for beat-to-beat BP measurement, and central venous catheter, for CVP and SCVO2 monitoring. Fluid resuscitation with 30 milliliters per kilogram of isotonic crystalloid, 0.9% saline or balanced solutions like lactated ringers, is initiated within the first 3 hours. Each liter increases stroke volume by 10 to 15% in responders, defined as greater than 10% increase in stroke volume or greater than 15% increase in pulse pressure. Fluid responsiveness should be assessed using passive leg raise, PLR, or stroke volume variation, SVV greater than 10% on mechanical ventilation. After 30 milliliters per kilogram, further fluids should be guided by dynamic parameters to avoid fluid overload, which increases mortality, or 1.8 if 4L in first 6 hours. Key points: community-acquired septic shock, e.g., pneumonia, pyelonephritis. References: 1. Scott H.F. et al. Clinical Decision Support for Septic Shock in the Emergency Department, a Cluster Randomized Trial. Pediatrics. 2025, 156, 1. PMID, 404902252, https://pubmed.ncbi.nlm.nih.gov/404902252. DOI 10.1542/PEDS.2024-069478. 2. Huang J. et al. The Association Between Mortality and Door to Antibiotic Time, a Systematic Review and Meta-Analysis. Postgraduate Medical Journal. 2023, 99, 1175-1000-1007. PMID, 369178816, https://pubmed.ncbi.nlm.nih.gov/369178816. DOI 10.1093/postage/CAD 024. 3. K et al. A Critical Assessment of Time to Antibiotics Recommendations in Pediatric Sepsis. Journal of the Pediatric Infectious Diseases Society. 2024, 13, 11608-615. PMID 39301933. https://pubmed.ncbi.nlm.nih.gov/39301933. DOI 10.1093/TID/PIE100. 4. Q-N-S et al. Appropriate timing of antibiotic initiation in patients with sepsis or septic shock, a systematic review and meta-analysis. The Korean Journal of Internal Medicine. 2025, 40, 5725-733. PMID 4085989. https://pubmed.ncbi.nlm.nih.gov/408598909. DOI 10.3904/Jim.2025.037. 5. Rodriguez Mr. et al. Early empirical antibiotherapy in patients attended for suspected sepsis in emergency departments, a systematic review. Emergencias, Revista de la Sociedad Española de Medicina de Emergencias. 2025, 37, 144-55. PMID 398989946. https://pubmed.ncbi.nlm.nih.gov/39898946. DOI 10.55633/S3me/092.2024. 6. Berluis NG. A mini-review of point-of-care C-reactive protein testing in sepsis in the emergency department. EGIFC. 2026, 37, 2260-267. PMID 42006505. https://pubmed.ncbi.nlm.nih.gov/42006505. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.